Department of Management of Relapsed Refractory FLT3 Positive AML. Today we have amongst ourselves Dr. Paresh Vyas. Sir is Professor of Hematology, Consultant Hematologist, Group Leader, MRC Molecular Hematology Unit, Department of Hematology, Weatherall Institute of Molecular Medicine, University of Oxford. Sir will be discussing today about the management of relapsed refractory AML and role of Zospata in FLT3 positive patients. Post that, we'll have a case presentation and a short panel discussion. Sir, if you want to share your screen, we can start with your talk.
Yes, I've sent a request so that I can share my screen. The host isn't allowing me to share my screen.
Sir, can you please try again?
Yeah. Okay. Can you now see my screen?
Yes, sir.
Is that okay?
Yes, sir, we can see your screen.
Great. Thank you very much. I'm sorry, there was a confusion about the timing. I'd like to thank the organizers for asking me to speak. My name is Paresh Vyas. I'm a clinician who looks after patients with acute myeloid leukemia. I plan clinical trials for the United Kingdom and Europe, and I work very closely with colleagues in the United States. Today, we're going to talk about the management of relapsed refractory FLT3 mutant AML, and specifically the use of Zospata or gilteritinib. So the next slide just shows my disclosures. And if we now move on, the outline of the talk, I'm going to give you some background on FLT3 mutant AML and FLT3 inhibitors, and then the treatment of relapsed refractory FLT3 mutant AML. Let's start by first reviewing the mutational landscape of AML. And in a talk that I gave yesterday with the Bengal Society of Hematology, the organizer pointed out that many years ago, when Martin Tallman came, it was 7+3, and it was one treatment in induction, Aracene consolidation. Of course, now we have a much better understanding of acute myeloid leukemia, particularly the genetics, and one mutation stands out, and that's the FLT3 mutation. So what is FLT3? FLT3, I hope you can see my arrow, is a molecule on the cell surface of blood cells, normal and leukemic. It binds FLT3 ligand, and the binding of ligand to receptor activates signaling pathways that lead to cell growth and survival, particularly in the progenitor compartment. Now, FLT3 RNA and protein is overexpressed in AML compared to normal cells, but crucially, mutations in the receptor that I'm showing you here cause a block in proliferation, a block in differentiation and excessive proliferation. So if we now look at the receptor in some detail, this is the extracellular domain, this is the cell membrane. There are two kinds of mutations, internal tandem duplication mutations, in what's called the juxtamembrane domain, so next to the membrane. There are mutations in the tyrosine kinase domain down here, and there are activating point mutations in other parts of the molecule. 3/4 of the mutations are ITD, 1/4 are point mutations TKD, and the activating mutations are rare. So if you look at young patients under the age of 60 who've been intensely treated, this is a paper from 2016 looking at the frequency of mutations, you'll see FLT3 is the single most common mutation in Caucasian populations with acute myeloid leukemia, 20% FLT3 ITD, 5% FLT3 TKD. If you look in older patients, the older you get, the frequency of the mutation is reduced. This is our data published last year in JCO. 18% in patients over the age of 60 were intensively treated. And then this is our data from 2017 showing in old patients who have non-intensive treatment, it's about 16%. So Typically, these mutations have been associated with poor prognosis, but the use of FLT3 inhibitors has changed some of that. And in the ELN 2022 guidelines, you'll see ELN 2022 classification, FLT3 mutations are primarily intermediate risk. With the NPM1 mutations, you improve this risk profile. The mutation really identifies patients who benefit for the FLT3 inhibitor treatment. There are a number of different ways in which you can identify this mutation. Most typically, it's done by PCR and then either next generation sequencing or using a gel electrophoresis assay, but typically sequencing. And this assay is pretty sensitive. It's highly specific. It detects both ITD and TKD mutations. And this mutation analysis now has become so sensitive that it's also used for MRD. And we may talk about that in the discussion. So the ELN recommendations for FLT3 mutation testing as a companion diagnostic are at screening, at diagnosis, and then also during treatment, especially at relapse, and we'll talk about that. And there are standard commercial kits available that most hospital laboratories can now use. Turning to the inhibitors, there are two broad classes of inhibitors, so-called type 1 inhibitors and type 2 inhibitors. So the type 1 inhibitors here bind to the receptor in an active conformation, and gilteritinib or Zospata and midostaurin are exemplars of that. Type 2 inhibitors really bind only in the inactive conformation when it's a monomer. And here, you really can't target TKD mutations, you just target ITD mutations, and quizartinib and sorafenib, which I think is used in India, is an exemplar of that. If you look at the kinome, i.e. what kind of kinases are inhibited by these different inhibitors, you'll see midostaurin is a pretty dirty drug. It inhibits lots of kinases. By contrast, gilteritinib is much more targeted against FLT3. It's really much more potent. It's 2 log orders more potent than midostaurin. Sorafenib is here, and it's intermediate in between midostaurin and gilteritinib. So let's now turn to the treatment of relapsed refractory AML. The first thing to say is the FLT3 mutation, when detected at relapse, is a poor prognostic marker. This is data from the MD Anderson some years ago. It's a retrospective single-site chart review analysis of 127 patients treated over a 10-year period nearly. 47 had FLT3 ITD. And you can see in the black line, the ITD mutant patients are doing worse than the ITD wild-type patients. And this was a FLT3 ITD based on a PCR assay. So they have shorter overall survival in first relapse. And the impact of first relapse, if then detected in terms of what is the survival, second CR survival, so you'll see that the survival is much less. FLT3 positive patients, though the numbers here are pretty small. So if you achieve CR, how likely is salvage to work? If you were FLT3 mutant, you were successfully salvaged, your survival is far worse than FLT3 wild type. And not surprisingly, your CR duration is commensurately shorter. So here we just see the overall survival, 23% at 2 years for FLT3 mutant versus 40% for FLT3 wild type, and this is highly significant. A key point to remember is that the FLT3 mutation is a late mutation in the course of AML. And so sometimes it can be lost, but it can also be gained during treatment. So here we have a number of studies. Please just focus on the last row here, which is the total. And you'll see these are the number of patients, 52%, 54%, who are FLT3 wild type, both at diagnosis and at relapse, presentation and relapse. In contrast, there are patients who are negative at initial diagnosis, but positive at relapse, that's about 12%. And conversely, who are positive at presentation, but negative at relapse, it's about 6%. Positive at both stages, about 28%. But this instability in the mutation means that it's really mandatory to test at relapse before you start inhibitor treatment. Just because they were positive at diagnosis doesn't mean they'll be positive at relapse. And just because they're negative at diagnosis doesn't mean they'll be negative at relapse. So the key points really I want you to take away from this first part are mutations are common in FLT3. It'll be very interesting to see if in the Indian population those frequencies are the same. In Bengal, they felt it was slightly lower. The prognostic effect of these mutations, particularly at relapse, leads to reduced overall survival. And the use of the inhibitor is important. Multiple case series have shown that the mutation status can change between diagnosis and relapse, so testing must be carried out at diagnosis and at relapse. Let's just talk about the Admiral trial. This was the pivotal phase 3 open-label multi-center randomized study of gilteritinib versus salvage chemotherapy. It included non-intensive therapy in a minority of patients. All patients had mutation-proven relapse refractory acute myeloid leukemia. There were 371 patients, a large trial, randomized 2-to-1 between gilteritinib 120 milligrams once a day and salvage chemotherapy. I'm not going to go through all the details here, but the gilteritinib was administered continuously. There were dose modifications and dose delay, particularly for cytopenia. And it was administered until there was loss of response or loss of clinical benefit or side effects that led to discontinuation. Patients who were eligible for transplant were allowed to proceed to transplant and then resume gilteritinib post-transplant. So we'll look at all of these different parameters in a minute. In the salvage chemotherapy arm, it was pre-specified what salvage was used. And at the end of salvage, folks were allowed to continue to transplant if that was deemed suitable. The primary endpoint is overall survival, a large number of secondary endpoints. The inclusion criteria are very straightforward. Primary AML, refractory or relapsed after first-line therapy, with or without prior allo transplant. You had to be mutation positive. You had to have an ECOG status of 2 or less. You had to pre-select your salvage chemotherapy, and you had to have normal liver and renal function. I'm not going to go through all of these exclusions, but the key point here is that patients who were relapsed or refractory to more than one line of treatment were excluded. The patient disposition in the trial was very balanced. The median age was 62, 61, 62. I'm not going to go through all of this, but the vast majority of patients, over 85%, 87, 91%, were ITD positive. There were a small number of TKD patients, and that just reflects the fact that TKD is a much easier disease to cure than ITD. So this is the primary endpoint, the median overall survival with single agent monotherapy gilteritinib versus salvage chemotherapy. You can see a pretty clear difference in survival, 9.3 versus 5.6 months, with a very impressive hazard ratio. It was also true for TKD alone, but of course here the numbers are smaller. If you look at the subgroup analysis, and I apologize, these subgroups are very small, but just focus on this line here, the middle line. On this side, gilteritinib had a better effect than salvage chemotherapy. And you'll see most of these squares are on the gilteritinib side of the line, other than some of these variables where there were very small numbers of patients involved, and therefore the error bars are small. But you can see that the monotherapy works in patients under 65, over 65, regardless of gender, regardless of race, regardless of ECOG performance score, but there were fewer patients with 2 or greater, which is protocol defined, of course. It was impressive in both ITD In TKD, it crosses this boundary just because the number of patients are small. Okay, this is just the modified EFS survival with long-term follow-up. You can see here in this population that the EFS is better, and this was a pre-specified sensitivity analysis with gilteritinib giving you 2.3 months and salvage chemotherapy less than a month. Very significant hazard ratio. If you now look at those patients who had a bone marrow transplant in the gilteritinib arm, what was the survival post allogeneic stem cell transplant if you received gilteritinib, and what was the impact of maintenance therapy with gilteritinib? So if you had a transplant and resumed gilteritinib, you're in the blue line, 16.2 months median overall survival. If you did not restart gilteritinib, 8.4 months. Our clinical practice is always to resume gilteritinib if we can. This is looking at overall survival in the gilteritinib group, and this was censoring at the time of transplantation, gilteritinib versus salvage chemotherapy, i.e. in those patients who had a transplant prior gilteritinib gave you a bigger survival than salvage chemotherapy. So if you're going to take a patient to transplant, you do better with prior chemotherapy, and post-transplant, you do better with maintenance gilteritinib post-allograft. This just shows you the the composite CR rate, so CRH, CRI, CRP, and composite CR rate. And you can see it's double in the gilteritinib arm versus the salvage chemotherapy arm, and of course that's reflected in the OS. If you were transfusion dependent prior to treatment, you're more likely to become transfusion independent if you had gilteritinib. And this is shown here, 34.5% became transfusion independent with gilteritinib. And that's not surprising because the CR rate is so much higher in patients who had gilteritinib. You also became transfusion independent for red cells and platelets. So if you had platelet transfusion dependency, you also had a better response with gilteritinib. Just thinking about the duration of remission in the first table here, the duration of CR in months was 14.8 months with gilteritinib. It was not evaluable in the salvage chemotherapy arm. I'm not going to go through all the other CRs. And in terms of dose reduction and dose increase, there were a fair number of patients who had a dose reduction from 120 to 80. Some patients, they were able to increase the dose, and this was those individuals, particularly who had robust reconstitution, particularly after transplant. But in my practice, most patients end up getting 80 milligrams. In terms of the safety profile treatment emergent adverse events, let's just focus on grade 3 and more in the gilteritinib arm. You can see if you compare gilteritinib versus salvage chemotherapy, really there is not much difference between the two arms, except for a small liver signal. There is a transaminitis in gilteritinib versus salvage chemotherapy. We've certainly seen it. But the other common treatment emergent adverse events are cytopenias, which you would see in relapsed refractory AML. And they really are not very different between gilteritinib and salvage chemotherapy. Now, there are some specific safety issues, which I'll talk about with gilteritinib in a moment. Not surprisingly, if you're doing well on gilteritinib, you're much more likely to stay on gilteritinib. And the median duration of exposure to gilteritinib was 18 weeks. Interquartile range 9 to 34 with a total treatment exposure in 121 patient years. So really, you're much more likely to stay on treatment with gilteritinib than with conventional chemotherapy. Here, I'm just showing you long-term follow-up demonstrated the continued and sustained benefit of Zospata or gilteritinib up to 3 years. So this is just extended follow-up, 37.1 months. And this is published after the main trial. And you can see that the survival curve split pretty early on, and that survival advantage is carried on through time. Okay, I'm just going to talk a little bit about transplantation here. So if you take the entire Admiral population, 64 patients received transplant, only 19 in the salvage chemotherapy group. And if you resume gilteritinib post-transplant, you can see you're more likely to be alive than if you did not. And that just speaks to the earlier survival curve that I showed you. Okay, let's just talk about the clinical outcome of those patients who receive gilteritinib in the relapsed refractory setting, but who've received either prior midostaurin or sorafenib. And this was an important set of data because more and more patients will come to relapse having had a prior FLT3 inhibitor. So this is data from the Chrysalis and Admiral trials, which has been combined. The patient disposition is hard to read, but you can see that the number of patients in Chrysalis who had prior TKI was 33, and in the Admiral trial, with gilteritinib, it was 31. So you're talking about a data set of about 64 patients. And in the salvage chemotherapy arm in Admiral, it was only 14 patients who'd had prior TKI. So difficult to compare, but we can certainly look at the gilteritinib data from Chrysalis and Admiral, 64 patients. And you can see if you had prior TKI, the overall survival in the Chrysalis trial, gilteritinib 120 or 200 milligrams with prior TKI is in blue, gilteritinib 120 or 200 without prior TKI, it's in red. And you can see that the survival curves really don't separate until about 9 months. And then you'll begin to see a difference. But the median survival is 7.2 months versus 7.5 months. So there is a difference, but it's late. And we would, in our practice, if patients have had prior TKI, we try and take them to transplant in this period when the survival curves really haven't split. This is the Admiral data, and again, gilteritinib with prior TKI in blue, and here you have salvage chemotherapy with prior TKI, blue versus green. The number of patients is small in green. This is the data without prior TKI in red, and salvage here, and you can see again, whether you have prior TKI or not, gilteritinib is better than salvage chemotherapy, and these are the median overall survivals, as you can see. Okay, let's now think about how long you have to stay on gilteritinib monotherapy if you are treating relapsed refractory FLT3 mutant AML. And this was a post-hoc study using both the Admiral and Commodore trial data sets. And patients were early responders if they'd achieved CRC by cycle 2, late responders if they achieved CRC after cycle 3. And there are a number of variables analyzed. And CRC, the composite CR rate, was defined as CR, CRh, and CRi. Okay, let's just look at the data. And you can see that this is the key graph here I want you to focus on. And you can see this is cycle 2, i.e. 2 months, 4 months, 6 months, 8 months. And you can see that you get more and more patients achieving CRC, composite CR, with time. In our practice, we really give 6 months. If the patient is tolerating treatment, we give 6 months before stopping gilteritinib, because the number of patients who respond will improve. And even if you get a first response, that first response improves over time. So a higher proportion of patients who are early responders in gilteritinib arm compared to salvage chemotherapy, but also improving response with time. Okay, I'm not just, for the sake of time, I'm not going to go through all of the early versus late responder data, but the key thing I want you to remember is whether you respond late or early, your overall survival really doesn't change. So responding after say 3 or 4 cycles, you will have a similar survival to if you responded early. In terms of patients achieving CRC, who had hematopoietic transplant after achieving CRC on gilteritinib, really not a huge difference, 23.3% early responders, 18.9% late responders. I think this just reflects the ability to take patients to transplant more easily and in a better shape. But even if you respond late, you can take people to transplant and their survival is really not bad. Okay, so the post hoc Admiral Commodore investigator conclusions are that most patients with relapsed refractory FLT3 mutant AML achieve composite CR within 6 cycles. Late responders were more likely than early responders to achieve full count recovery. Late responders frequently underwent stem cell transplant. We saw that. And fewer late responders experienced treatment discontinuation due to disease relapse. So do try and keep your patients on for at least 6 months. There are some special warnings and precautions. I'm going to talk about differentiation syndrome, but I'm also going to talk about PRES, just say a quick word about pancreatitis and prolonged QTC and contraception. So there is definitely a small number of patients who achieve a response to gilteritinib and have differentiation syndrome, much like APL, or indeed with the menin inhibitors, which some of you may have used in clinical trials. About 2 to 3% will be getting differentiation syndrome. And it's classic differentiation syndrome with fluid retention, dyspnea, pleural effusion, pericardial effusion, pulmonary edema, weight gain. They may have renal dysfunction. Please use first line, stop the treatment. Second, give corticosteroids and whatever supportive care you need to give. And the management is pretty straightforward. You do exactly the same thing in APL. In terms of PRES, as you know, this is a clinical diagnosis in the first instance, reversible neurological order, typically with seizure, headaches, and confusion, occasionally with other disturbances. And MRI is the imaging of choice. So with the right MRI appearances and clinical appearances, you can make a diagnosis of PRES. It is usually reversible. We've never seen this cause long-term neurological sequelae. So just stop the gilteritinib. You cannot restart if you have PRES. Pancreatitis, I've never seen it, but it is reported. So the classic symptoms and signs of pancreatitis: stop the gilteritinib, provide supportive care. All patients must be on contraception. This is both males with female partners of reproductive potential, male patients, or female patients really must take adequate care here. There are some interactions with other drugs, and this is because gilteritinib is metabolized by CYP3A. So do think about your antiepileptics. Do think particularly about your azoles, which you'll be using, your macrolide antibiotics, and also in clinical practice, rarely you may be thinking about midazolam when you use bone marrow biopsy. So the summary of the Admiral trial is a phase 3 open label multi-center trial. And really it shows that gilteritinib monotherapy is superior to salvage chemotherapy in first relapse, including in patients who've had a prior hematopoietic stem cell transplant. More patients will proceed to transplant with gilteritinib, either a first or second transplant, and please maintain gilteritinib post-transplant. These results really were very important in the treatment of FLT3 mutant AML. I'm not going to go through the last 2 slides, and I'd just like to thank you for your attention. I'd be happy to partake in the panel discussion.
Sir, we have one question in the Q&A. Do you want to take it now, or should we reserve it for the last?
We can do it now, and I'll also, I'm sure there'll be additional questions in the panel discussion, but I'm happy to take a question in the Q&A now.
Right, sir. There is just one question. In relapse, if the patient is both FLT3 and NPM1 positive, will you prefer salvage over gilteritinib?
Yeah, that's a great question. So today, in patients who have FLT3 and NPM1 dual positive mutations, there are a number of choices, but the FLT3 mutation is really important to treat. And so typically we would give gilteritinib, but we would probably give it in combination with veneza, because veneza responds, NPM responds pretty well to veneza. I should also say that there are trials that are about to start of FLT3 inhibitors with menin inhibitors, specifically for this group of patients. But I would definitely include a FLT3 inhibitor at relapse when they're both positive.
Thank you very much, sir. So there are not any more questions as of now, but if at all we have it during panel discussion, you can take it then.
I think there's a question in the
There
chat
is,
about
one more question, sir.
yeah, how long to continue after transplant? This is a great question. There isn't a clear-cut answer. In my clinical practice, I continue for at least 12 months post-transplant. Most patients will relapse within the first 12 months post-transplant, as you know. We have the good fortune of having FLT3 MRD. And if there was one test I would recommend beyond NPM1 MRD, molecular test, I would recommend FLT3 MRD. It's a commercial kit. And so if we are FLT3 mutant MRD positive at 12 months, we carry on with gilteritinib. If we are FLT3 MRD negative at 12 months, we stop gilteritinib. That's our clinical practice.
Yes. Thank you again, sir. I do not see any more questions coming in. So we can skip to the next, move to the next session, and then in the panel discussion, we can discuss next. Yeah, thank you, Anshika. I would now like to welcome Dr. Sushil Selvarajan. Sir is going to take a case presentation on role of Zosparta in relapsed refractory FLT3 positive AML. Sir is an associate professor, Department of Hematology at CMC Hospital, Vellore. Sir, over to you. Would you like to present your own slides, sir, or should we do it at our end?
Yeah. Hi, Prajakta. No, I'll present. I'm sharing my screen. So
Yes, sir, it is visible.
Yeah.
We can see the presentation as well.
Yep. Great. Thanks to the SLS team and for this opportunity. And it was really a pleasure to hear from Dr. Vyas. A wonderful talk as usual. And I think it really sets the stage for all of us to consider where we want to use gilteritinib in our practice. And I think this case will sort of highlight many of the issues that he had brought up. So I'll quickly go on to it. I'm Sushil from CMC Vellore. I'm faculty here, and it's my pleasure to meet you. Slides visible, Prajakta?
Yes, sir, they are visible.
Yeah. So I'll quickly go on to talk about Mrs. N. So she came to us last May, and she was a 48-year-old housewife, a diabetic for 2 years, but otherwise fairly well preserved. She had a history of low-grade fever intermittently for the past month prior to presentation and occasional bleeding from gums. Her baseline parameters, as you can see, just showing cytopenias in the hemoglobin and platelet parameters, but the WBCs are of 68,000, and the smears there clearly showing, sorry, my mouse is not, yeah. The smear showing blasts, atypical cells 83%, blasts clearly looking like AML blasts. And the marrow that we did showed 71% blasts. They were pass negative, SBB more than 3% positive. Less than 20% positive for non-specific esterase, 80% positive for specific esterase, looking in keeping within monocytic AML. And the biopsy was also consistent with an acute leukemia. The flow clearly showed an AML with monocytic differentiation, as you can see with the flow gates that I've put up here. And I'll quickly go into the details. So we actually, as per our recommendations, as per our guidelines in the institution, we proceeded with 7-3 because she was fit for it. She did not have any infection at presentation. But by the 5th day, she developed high-grade fever and became hypoxic, something that we see unfortunately all too often. And by that time, we had her PCR. NGS came a little later, of course, but her PCR showed NPM1 positivity, FLT3 positivity, ITD positivity, and TKD was negative. The NGS, which came 10 days later, showed DNMT3, NPM1, and FLT3 positivity. And I'd like you to remember these three specifically, which are a very notorious triumvirate of mutations. And yeah. So, to cut a long story short, she went through a torrid course. We stopped her chemotherapy on the 5th day, so we didn't give her 7 days of cytosine. We stopped it on the 5th day. After she went into septic shock, ARDS, early MODS. She also had an acute pancreatitis, most likely drug-induced. The complication was a fungal rhinosinusitis, which grew fusarium and Candida auris. With great difficulty, we took her through the cytopenia period, and she recovered her counts by around day 24 post-induction. At the bone marrow reassessment that we did on the 25th of June, you could see that the aspirate, while did not show any morphological evidence of disease, the biopsy showed this sinister population, CD34 positive immature precursors of 10 to 12%. And the AML MRD, unfortunately, was 2.4% showing positivity. And so this we know the NPM1, DNMT3, and IDH often, and along with FLT3, of course, leads to inferior overall survivals in this group. This is notoriously a bad group of. The moment we got this mutation profile on the next-gen sequencing, we had counseled the family towards transplant, and her brother was a full-matched donor. Unfortunately, given the fact that she still had disease, and even if we had cleared the marrow, we knew that she wasn't fit for a transplant as she was recovering from her gross fungal infection, rhinosinusitis, and fungal pneumonia that was resolving. We decided to give her azacitidine, but with the azacitidine, she also again became cytopenic, and then that's when we decided to put her on gilteritinib, initially at 40 mg. You'll remember that she had this acute pancreatitis, and as Dr. Vyas had just mentioned, that was a concern for us because of it was one of the concerns in the adverse drug events from the previous trials. So we started initially tentatively with 40 milligrams. Again, keep in mind that this patient, she was on an azole. She was on isavuconazole, so that was something that we hoped would also boost the gilteritinib levels initially. But this was mainly just to feel our way of how she was going to respond with gilteritinib, in terms of the side effects. Fortunately for us, despite the antifungals, despite her overall poor condition, she really responded. She really did not show any, did not have any side effects actually after starting gilteritinib for the first 10 days. And 10 days later, we managed to increase the dose successfully to 80 milligrams. It was well tolerated. And on gilteritinib 80 milligrams, we were able to stop. We were able to continue antifungals at maximum doses, and her fungal infections gradually resolved. You can see here, this is a sort of, after we stopped the azacitidine and the cytopenia recovered, over the next 2 months with gilteritinib, her counts really maintained beautifully. And this is something that was really very heartening for us to see. And at the end of this, after 3 months, a subsequent evaluation by the ENT people, PulMed, and the infectious disease team deemed the patient to have been fungus-free from all the sites. In the sense, they did cross-sectional imaging all across the board and found that there was no residual fungal infection. And they actually cleared the patient for a transplant if we felt necessary. And obviously, we did the reassessment bone marrow, and this time there was both morphological remission and MRD was negative. Again, this is flow MRD. That's, I think, point well taken about the FLT3 being a possible target for MRD in the future. However, it's not available at our institution. And we successfully took her up for a matched sibling donor transplant in CR. I just like to briefly talk about the fact that we know that normal FLT3 plays a role in early hematopoiesis, and some degree of myelosuppression is expected with any FLT3 inhibitor. The advantage of gilteritinib is that it's a much weaker inhibition of the wild-type FLT3 combined with its lack of activity specifically against KIT, which is a problem with some of the other FLT3 inhibitors. And the neutrophil count recovery often occurs fairly rapidly, and if the gilteritinib has the differentiation action on the major clone, it often has a earlier recovery than even 3 weeks. So in our case, there was no significant liver derangement or ECG change that we found. At doses used, no significant dose-limiting cytopenias were noted. And despite this patient's extremely poor ECOG at the time of starting the gilteritinib, an ongoing fungal infection on board and MRD positive status post-induction, and also most likely morphological disease on the biopsy, this patient really was taken up well through the transplant, and it's something I think that we learned from for future cases that we managed. And this is despite the fact that this patient had this DNMT3, NPM1, and FLT3 coexisting mutations. And which was all the more, I mean, it was our worry that, we were giving despite the other 2 mutations, would gilteritinib really work? And there was data to say that this is a group that gilteritinib really has a good effect in. And I think Dr. Mark Lewis had also mentioned this group as surprisingly responding to gilteritinib. And maybe Dr. Vyas could shed some more light in that regard. But yeah, I'll end my case here, and we'll...
That was great, Sushil. Just one point. I think post-transplant, I think it makes a point that we continue. And just for a query, venetoclax and even midostaurin, why was this like? Was there anything against it, and we kind of skipped out to gilteritinib? It has worked well, and it's going to work well for that, sure. Since the other mutations were there, was it a concern? Was it just the infection which prevented us from going any further into these additional drugs, which we right and left use in upfront AML, Sushil?
Yeah, so initially when we started 7.3, we didn't have the reports for FLT3 because the PCR takes around 5 days for us, the turnaround time. So we had started 7.3, and the plan was that if we get FLT3 reports positive, we often add on the midostaurin onto the first cycle. But by that time, she was too sick to consider any other drugs, and we really needed her to recover cytopenia at that point of time. It was, I mean, as you can imagine, a very touch and go situation, Dr. Kishore. And I think when we considered gilteritinib at that point of time, I think we were all fairly, at least I was fairly clear that she probably wasn't going to tolerate midostaurin. I mean, we've had quite a bad experience with the cytopenias, especially with in patients who are sort of fragile. So midostaurin was not something we considered, but sorafenib was something we were considering. But in this patient, I think we decided to go with the gilteritinib purely because of the mutational profile and the prior experience that showed that gilteritinib really was much better tolerated than sorafenib and worked in this particular mutation profile that this patient had. But I'd like Dr. Vyas's opinion on gilteritinib along with these particular co-mutations, Dr. Vyas.
Yeah, just there's several points. Firstly, congratulations on managing a difficult case. She's clearly done well. You're absolutely right. We agree with Mark Lewis that the triplet DNMT3A, NPM1, FLT3 responds well to gilteritinib. We've seen good responses. We've seen patients who had failed midostaurin and intensive chemotherapy with the triplet mutation respond to single agent gilteritinib, and then subsequently in trials to the triplet venetoclax, azacitidine, gilteritinib. I'm not sure of the mechanism by which this occurs, but I think the potency of the agent, it's 2 log orders more potent on FLT3, allows you to get better inhibition of FLT3 in this context. And certainly back when Mark Levis was doing this work, he looked at what's called the plasma inhibitory concentration. So he'd take plasma from patients on gilteritinib, and he's done it with midostaurin. And he'd show that the serum of these patients could inhibit FLT3 signaling much better on gilteritinib than with midostaurin. So that is a possible mechanism by which gilteritinib may be more effective. The other thing I would say is certainly in patients who are fragile, our experience is that both midostaurin and sorafenib do have challenges in terms of safety, in terms of tolerability. Midostaurin, it's a mixture of cytopenias and GI upset. With sorafenib, GI upset is quite an important issue. And post-transplant, it is a real issue because you kind of worry about graft versus host disease. And so therefore, the gilteritinib has a better safety profile in that setting. And in terms of, I would encourage you, if you can, to continue gilteritinib post-transplant. You can use your NPM1 mutation for much more sensitive MRD monitoring than flow, because typically DNMT3A will be the first mutation, NPM1 will be the second mutation, FLT3 will be the third mutation. So all cells that are FLT3 mutant will contain NPM1, and you can use that NPM1 marker as a really sensitive MRD marker.
Sorry, I didn't mention. So we do NPM PCR, NPM1 PCRs for MRD. So she was NPM1 negative. Okay, so
Great.
I hadn't thought of. Okay, sure. So are you saying that if there was an NPM1 and FLT3 co-mutation, we don't need to check FLT3 MRD in that scenario?
Well,
If we had NPM1?
Yeah, great. Well, it depends on the result. So we do both. Why do we do both? Because, as you know, the mutation is labile, right? It's a late mutation. So you can get situations where your NPM1 mutation, MRD mutation, positive, but you've lost your FLT3.
Yeah.
And in that situation, no point continuing gilteritinib.
Oh, okay. Yeah.
But you have to think about aza-ven, or you have to think about something else. If you are FLT3 mutant and NPM mutant, you have to continue gilteritinib. In our experience, GVL takes time, and particularly in patients who have had GVHD or ongoing GVHD, we are very worried about the immunosuppression, but clearly if they've got clinical GVHD, you've got to carry on immunosuppression. So having that MRD gives you radar. It's like radar looking into the deep future as to what you're going to do about disease. So if they have GVHD and they've got MRD positivity, we really like to continue some form of disease control.
Professor, we have just a thank you. Professor, we have just a small comment on the 40 milligram dose. Naturally, with the trial setting is entirely different in your personal experience, and we have the Indian Jugaad system always when it comes to any drugs for that matter because of the logistics that are concerned. So it has worked wonderfully with Sushil, and what is your comment on that?
So there are 2 points to make. I think the pharmacokinetics are always studied in Western populations. And I don't know if the Indian population will respond with similar pharmacokinetics, and I've never seen that data. What I would say is, if you are going to use anything less than 80, monitor disease. Because at the end of the day, what's going to kill the patient? It's the AML. So you can use 40, that's fine, but just make sure the disease is not coming up. And you have to do it. I mean, if you lose your CR, it's too late. So MRD is worth it because the test is cheaper than the treatment. So use it.
And Sushil did said about the complications when the patient was started on the. So do you think
I think you did exactly the right thing? I would have started 40
it's
as
like
well.
dose related, sir, like say the pancreatitis or whatever. Do you think it is dose related? Will it have an impact? I don't think so.
No, I mean, I haven't seen pancreatitis, so I can't say, but my impression is it's idiosyncratic. But in a patient who has pre-existing pancreatitis, to give gilteritinib, I would have been cautious, just as Sushil had. And, you know, you just hope for the best.
True.
Because, you know, if you disturb the liver anymore, if you disturb the pancreas anymore, you're worried. But in general terms, pancreatitis is a rare thing with gilteritinib. QTC is common, but actually clinically, I don't know how you feel about it, but I don't worry too much about QTC. I worry more about all the concomitant medications, making sure the potassium's all right, making sure the magnesium's all right. I don't stop gilteritinib because you have to have disease control.
So more like the arsenic trioxide, I should say. We do continue, but manage things.
Yeah, manage everything else.
Thank you, sir. Thank you.
Yeah, thank you.
Dr. Vyas, we do have a few questions for you.
Huh.
Would you like to take them right away?
Yeah. So the first question, I think, is FLT3 a driver mutation? Absolutely, it's a driver mutation. By driver mutation, I mean it is required for the phenotype, the clinical manifestation of the disease. You can get, of course, you can get AML with just DNMT3A and NPM1. You don't need FLT3 for the leukemia. But if you have FLT3, it's more proliferative. The relapses are faster. The tempo of the disease is higher. And you really got to suppress that signal. So it is a driver mutation. What is your stance in FLT3 and NPM1 mutant AML? If NPM1 becomes negative and FLT3 becomes positive, I have not seen that. Now, it could happen, but typically the FLT3 mutation is a later event than the NPM1 mutation. Now, of course, there will be somewhere in the world, somebody will have seen a patient where the NPM1 was negative and the FLT3 was positive. But of course, if the FLT3 is positive, you have to treat it. Make sure the lab has got the test right. Just make sure it's not a lab error. But if it's not a lab error, you have to treat it, even if the NPM1 is negative. But that situation will be rare. If the patient did not have a transplant and was treated with standard chemoinduction, 3-HDAC consolidation with midostaurin, do you start gilteritinib for MRD becoming positive? Absolutely. That's relapse. Just because it's not morphologic relapse and just because the Admiral trial did not treat MRD, that disease is not going away. That MRD will only increase. You must treat it. If I was a patient, I would not be happy with my doctors. So that's the answer to that question. What methodology for FLT3 MRD? There's a commercial test. In vivo Scribe now do something that goes down to 10 to the minus 6. But we use our own tests in the hospital because in vivo Scribe is expensive. And it's a test that is really simple. Peter Volk published it in Journal of Clinical Oncology. It's just a PCR test. And then there's a computational pipeline to look for mutations, which is very straightforward, not difficult. And in India, you have so much computational people, it'll be very easy for your lab to do it. If anyone wants any advice on that test and doesn't want to use the commercial kit, just email me. But if you want to use the commercial kit, use it. It's very good. Post-relapse on venetoclax, how are outcomes different compared to intensive chemo? You respond equally well if you have relapse on Ven/Aza as if you did with conventional chemo. It's the mutation that counts, not the prior treatment. Does GILT have any activity against a kinase called AXL? Honestly, I don't know. But I'm not sure how important it is. But I would have to go and look at the kinome properly to tell you. What is the duration of maintenance therapy? Post-transplant, at least 1 year. And in the context of folks who have just intensive chemotherapy, again, I would say 1 year, but please be guided by your MRD assays. Typically, I reduce the maintenance to 80. I don't go 120.
Thank you very much, Dr. Vyas, for taking up the questions and for an interactive discussion as well. Thank you, Dr. Sushil. I would like to now move on to our next session, that is a case-based panel discussion. I would like to invite Dr. Prashant. Dr. Prashant is Senior Consultant Unit Lead in charge of Hemato-Oncology BMT Unit at MVR Cancer Care, Calicut. Sir, we can see your screen and your slides as well. I will quickly also introduce the panel we have today. Obviously, Dr. Vyas will participate in the panel discussion. We will also have Dr. Sushil participating. And we have Dr. Kishore Kumar, Senior Hemat and BMT Physician, Miyot International Hospital, Chennai. We are also supposed to have Dr. Shrikant with us, who will be joining us shortly. There is some technical error at his end. He is joining us in another 2-3 minutes. Dr. Prashant, you may now continue from here. Thank you, sir.
Thank you. Am I audible?
Yes, sir, you're audible.
All right, Professor Vyas, it was actually a very enlightening presentation. I think so most of the things has been almost conveyed very clearly. So I think so we can make it very fast and brief. I think so Zospata or Gilretini, as well as we want to know what is happening in our Indian context. And I'll start with my Indian colleagues and we'll have an expert opinion from Professor Vyas. So I think so I'll start with Dr. Kishore. Barring the slide, a new AML come. What is a normal test you normally do for them for a genetic risk stratification in your day-to-day practice?
Yeah. To be more frank, I can put it like two ways, Prashant. To be more frank, incidentally, my DM thesis 12 years back was on FLT3 positivity in a government set of patients. So I did published it in Blood actually. I'll just read out what I did 12 years back and what I do now. So at the time, it was 68 patients what we did. It was on PCR, purely on PCR, and I had to do all the PCR stuff. So we had 24% of cases who were FLT3 ITD and around 5 to 6% who are FLT3 TKD, and the combo was 8%, overlap was 8% in our cases at that time. This was in 2011 to 14 when we never had all those NGS kind of stuff. So yeah, basic marrow, and I'm not sure even sometimes marrow with the NGS has been quite, the flow cytometry and NGS has been the basic investigations which we all do. And when it comes to FLT3, there has been quite a lot of confusion because Sir has very much talked about the nuances of how things. There is a point mutation, there is an intern tandem duplication. So sometimes earlier we used to always think that the NGS may miss out this ITD kind of stuff. But I think most of the places which are doing NGS have come up with this point because this is one of the commonest mutations, a targetable mutation. So this combo of PCR and then an NGS are somehow picking up that has come up as a combo of late. So even if you send an NGS for AML panel, that should pick up. But this always we have, whether the delay that happens is always there. So till on date, I should say I'm kind of, since we have an in-house PCR that is happening with FLT3, NPM and things like that, the typical CBF core binding factors, we do send the patients on PCR as well as NGS. I think slowly we may move to the single combo test for that matter.
Okay.
Apart from it, yeah, that's it.
Yeah, so PCR and NGS for all AML.
Yeah, right now we are doing that, but as I said, the combo test is going to include everything. So I have a worry of missing out this FLT3. So that's what we have been doing, but I think slowly the labs are getting more intelligent. Right. They can pick it up. Yeah.
Dr. Sushil, you will be having a lot of things in-house in Vellore. So you agree with this basic workup? Because we just want to know that whether we should not miss a FLT3, we want to get all other mutations. So what is the best way to go ahead with that?
Yeah, no, I agree with Dr. Kishore. I think that's broadly what we do. There are a few research basis tests we do here, which may help us subsequently, which we've started. But I think for the practical purpose of this discussion, that's it.
Okay. What about this comprehensive exome sequencing, Dr. Sushil? There has
Yeah.
been
So-
something comprehensive genomic profiling. Why I'm
So,
asking this question is, after starting doing this test, I have not seen a good risk AML. So whether they exist also, I'm not sure. So I just want to know the opinion.
Yeah, no, so we actually go beyond. We do germline testing. Okay, so actually, I didn't want to go into this, but yeah, so we have I mean, again, it's in the research setting, but we are doing germline. It's a funded trial, so we're doing germline testing for all our patients with myeloid malignancies below 50 and myelodysplasia below 40 years old. So we really do whole exome for most of our patients, and as you rightly said, lots of what lies beneath sort of comes up, and it's a problem. I don't know whether it's a problem. It's probably good for us to know, and then therefore better for us to give an informed decision to the patient. But I think Dr. Vyas probably faces this problem much more than us. So I think.
So how we should go ahead? What should we send actually? Whether we should see
No,
all
I think we should stick to guidelines. I don't think we should. I mean, at least in India, it probably doesn't make sense right now to expand panels and advise whole exome sequencing for everyone.
All right.
But yes, I mean, it will change in the future once. I think the next. I think the next log difference in price pointing when it comes to maybe $100 genome, that might be a point when we can get in. But I'm curious to hear what.
All right. Professor Vyas, can we have the final comments on this? What should we send?
So just send NGS.
Okay.
And there is a very simple bioinformatic pipeline called Get ITD. Very simple to implement. If you implement that on your NGS sequencing, you will pick up your ITDs. You will not miss them. And this was Lars Bullinger who published it in Blood. Now, I can't remember, maybe 5 years ago, 6 years ago. It's a bioinformatic problem. It's not a laboratory problem to get the ITD. And it's very straightforward. In terms of exome sequencing, my own view is we do not do that routinely. Okay. There is a government initiative for whole genome sequencing, blah, blah. But in routine clinical practice, we do not do it. And we do not do it because I think you will find many things and you will not know what to do with it. And so until we have clear guidance, I think it's difficult. I think the sequencing is going to become much cheaper. Roche has come out with a new sequencer. There are 2 American companies and 1 Chinese company that come out with new sequencers. So the price point will fall over the next 3 years. But that's not the main issue. The main issue is what do you do with the data? And so I think it's difficult. I think in terms of germline testing, we do not do it routinely in patients under 50 for ML or under 40 for MDS, but we do it where there is a family history. We do it and we come across DDX41 mutations, for example, all the time. And it's difficult to know sometimes what to do with them. So I would reserve it from a pragmatic point of view in those families where you have clear family histories. And then you have to get a skin biopsy if you're going to do it properly. And then you have to culture out fibroblasts. It's not cheap.
Yeah. All right. All right, sir. Coming back to our theory, that means in your experience, Dr. Kishore, that means how much you will rate about what is the percentage of FLT3 mutation you come across in day-to-day practice, in upfront setting and in relapse setting?
Yeah, my own data says up to 1/3 is what an approximate estimate. I say somewhere between 25 to 30%. And yes, we all know that AML is a polyclonal disease, and yes, relapses do surprise us sometimes. That initially things have been negative, and the practical difficulty is what are we going to do at that point. So of late we have started doing, because of the availability of all these targeted agents, we have started doing NGS in patients. Say a proper box standard 7+3 HiDAC went home 6-8 months back, coming back. So we are kind of doing it again. So and we do see new mutations coming up, especially for that matter, FLT3. So this is what it is. 1/3 is what I put it.
Okay. There have been some publications, I think so, from Ahmedabad. People have seen molecular oncology, and they've told South India there is more incidence compared to the northeastern India. In Assam, it is around 15 to 17% is what they were telling.
Sushil also will say because most of his patients are from the eastern part of the country. And
Yeah, Vellore will have more numbers from Bengal. What is your opinion on that, Sushil?
No, I'm at our data, published data is 20%. But again,
20%. So it is less
if we,
compared to.
yeah, yeah.
Okay.
So,
And about
Yes.
TKD, Sushil?
sorry.
TKD?
No, I was talking about any FLT3 mutation. We're at
Okay.
20%. ITD is actually 15% in our population, 15.6 or something it was. I can't remember exactly, but that's what we had in our newly diagnosed AMLs.
Okay, because so there's definitely a difference among the people because we had a 26%. So I think so. We all are dealing with pure South Indian population, but I think there will be a lot of Northeast India where Vellore is covering. All right. What about this discrepancy, Dr. Sushil? You have seen, because I have never seen, even though 12%, Dr. Professor Vyas has given the exact number of discrepancies that happen where negative becomes positive or positive becomes negative. Have you seen in your day-to-day practice where he was upfront negative and on relapse he became FLT3 positive?
Oh yeah, that is definitely something we see. A problem is that we get many referral cases, so they are outside negative. So I'm not very clear about how good the testing is.
Lab is.
But we have enough cases that are present with FLT3 positivity at relapse. I don't know the exact numbers though. In our relapsed, in our RR-AML setting, it is close to 28% that we have FLT3 positivity in. Now that's probably, the
These
only
are the
figures
patients who are upfront tested negative.
No. That's I just told you that it's in all RR-AML patients.
Okay.
It is.
All right.
I don't know the numbers for how many were
All right.
initially
No issues.
positive, but it is definitely sizable because off the top
Professor
of my head I
Vyas
know that.
today told that negative becoming positive is around 12.7%. So it's pretty big number.
That's probably something else.
Yeah. All right. I'll start with Dr. Kishore and we'll have the final point from Professor Vyas. That means while we treat an AML, what should be the endpoint?
I'll say a very practical endpoint, Prashant, across the world, I suppose in India, 3-year survival rate is only 20%. This is what I say to my patients very practically. Let it be any drug, anything. This is because like a confounding bias is all about the sepsis, even Sushil's case for that matter. Nothing was preventing from a box standard 7+3, but we weren't able to do that. And grossly put it across, I work in a corporate, I have been from a government setting. So there even patients getting treatment was, if you consider everything, the 2-year survival rate was only 15%, 1.5. That was the reality. 5 out of 6 I was losing when I was in a government setup. And now if you really ask me, yes, my endpoint at the end of the day, if I am a patient, I want to be alive, as simple as that. So I want to be clear of the disease. I want to be alive. I want to that's very simple. You may talk about data nonsense, but go to the SEER database that says 30%. That's all. That's the practical reality. But one thing we are very clear is hit hard at the first time. So that has been a way we want to do. So use everything, say like Arkansas's Little Rock policy of just doing a complete therapy, because many times in our patients, that's the only chance we are going to get. We are kind of non-sponsored patients. They get lost to follow and finances are an issue. So many times the practical reality is any AML, let it be, as you said, more and more NGS we are doing, more and more mutations we get, and nearly everybody becomes a high risk. So even risk stratification doesn't mean much. If there is a proper MSD, a mass sibling donor and all, our aim has been to get into a decent CR, get onto a transplant. So yes, I have talked about NPM being a good risk, etc. But I can show you a lot of FLT3 is doing excellently well, doing nothing, just my 6 months of midostaurin or something. So it's all written somewhere here. So our aim has been to hit it hard, consolidate with the transplant if possible, if they're eligible enough. That's very simple, very clear. If I'm not able to do that, MRD has been quite a confusing thing. And even to get onto a transplant, I'm not very stringent on my MRD. I've been very clear in this point also. And especially the availability of post-transplant maintenance regimens like gilteritinib, I think that makes a lot of sense to get going with some induction, get an MRD negativity, decent MRD negativity, do a transplant, put them on some kind of a maintenance. So this is what I'm aiming at.
Professor, we ask any wisdom pearls, comparatively young. So we are trying to cure majority of the AMLs, but we so what is your opinion the endpoint should be?
So, what counts as OS? So, Dr. Kishore is completely right. OS, survival. It really depends for me on the age. So, most patients, I don't know about in India, but that AML increases with age. So if you're 75, if you're 80, it's a different ball game than if you're 35, 50, 55, 60, 65. 65, is different for some reason, is different from 75, 80. And it's maybe you've just stopped working and you think, how can I not live? I want to see my grandchildren. Whereas if you're 75, 80, do you really want to go through all these things? So it's a big conversation with the patient. But if you are going to be treating intensively, Dr. Kishore is right. Hit hard, hit early.
Yeah.
The reason for that is simply that relapse disease is much more complicated than just the mutations. For reasons we don't fully understand, nobody in the world understands, relapse disease is just harder. Now, if you have a single agent mutation like FLT3, whatever, yeah, you've got a chance. NPM1, you can use menin nowadays and other things. But look, hit hard, hit early. The one exception for not going to transplant very clearly is CBF, core binding factor leukemia. Here, you will have Mylotarg. Use daunorubicin, use anthracycline, use Mylotarg. I do not take those patients to transplant unless they are MRD positive, which is
all
rare.
CBF or only inversion 16. 821 is still bad, I think.
Yeah, so I don't know what your experience is, but
We don't
821.
have Mylotarg. We don't have Mylotarg in India.
You don't have Mylotarg.
No, we don't have.
Okay. That makes a difference. That's terrible. Pfizer should be ashamed.
Inversion 16 is doing well. That's my opinion. But 821, they don't do well. The KIT or whatever this mutation is happening on them.
Yeah, there's KIT mutation.
Yeah.
And if you have a KIT mutation, do you have dasatinib?
We don't have.
No, we do.
What?
Dasatinib.
Dasatinib we have.
Yeah, so dasatinib is a reasonable KIT inhibitor. And I've used dasatinib for patients with KIT mutations with 821 or inversion 16. And it's done well. And it's helped us take people to second transplant in a very good situation. So that would be something you might consider. The thing we'll say for all of you is that in the next 5 to 10 years, some of this will change when we get triplets. So veneza plus X. And some of these will be very effective. I've been so impressed with the menin inhibitors. In our practice, we've treated maybe 18 patients with relapsed refractory AML, both KMT2A and NPM1. Every single patient's gone into CR with monotherapy. And now we're doing the combination study. So if you have a chance to do those trials, and those trials are opening worldwide, J&J are doing it, Sumitomo are doing it, Cura are doing it, Syndax are doing it, try and get involved, because it will be a drug that will be part of AML treatment.
Yeah. All right. Thank you, sir. So the first case is basically a 36-year-old who had got that triplet mutation, TNMT3A, FLT3, and NPM1. So routine, as Dr. Sushil was presenting, 7+3 was given, midostaurin was given on induction, and followed by HiDAC and midostaurin consolidation. She relapsed with around 48% blast. So the question they wanted to ask, I'll start with Dr. Sushil itself. Whether what other test would you prefer to do before starting subsequent therapy? Would you do the FLT3 testing again?
Yeah, I think that's fairly clear after our discussion. We would definitely do a complete genomic profiling on this relapsed AML.
Okay. So NCCN or whatever guidelines which you are following, they tell that you have to do a repeat comprehensive genomic profiling because it's dynamic, as Professor Vyas has also told, and there are options of targeted therapies as of now, and you don't have to always rely on chemotherapy. PCR or NGS for FLT3 testing, Dr. Kishore, in one line, it's in the relapse setting, you again go for NGS?
Yeah, I think NGS, Prof has very clearly sold their intelligent NGS of late, which can pick up everything.
You have an in-house facility. Vellore has an in-house facility, I know.
Yeah, NGS we don't have. We have the PCR for in-house as a facility. NGS we outsource actually.
Okay. What is the turnaround time for an NGS? 3 weeks?
Yeah, same med genome. So it all depends. So,
Yeah.
3 weeks.
In Dr. Sushil, whether in Vellore both ITD and TKD both are checked?
Yeah, both are checked. I mean, whether we
Point
react.
mutation, everything.
Yeah, I mean, it's point. All mutations are checked. All polymorphisms are checked. But I mean, we don't have the flow PCR. The PCR NGS for MRD, which we're trying to get from Peter Mac. But I think I'll talk to Dr. Vyas maybe after this to see what how we can work on that, because that's something we've not been able to implement. So.
Okay. So patient has tested FLT3 positive again. So now, considering she is 36 years, Dr. Sushil, our goal will be for complete remission and transplant. Your opinion?
Yeah, definitely. I think that's what we should go. I mean, when we say CR, I'm not so particular about the MRD in AML, but definitely morphological CR and transplant. There's lots we can do with the post-transplant adjustments, including GVHD prophylaxis, DLIs, frequent chimerism, split chimerism, and MRD testing to modify the post-transplant course. So we would like to take the patient up for the transplant in a CR, though. That is for sure.
Professor Vyas, as you have been using lots of Sospata in your practice, you told about 6 months time. That means in this type of patients, how long we should wait for an MRD to happen?
So it depends if you're giving monotherapy or if you're giving gilteritinib with other things. So I don't know what your local practice is, but in our practice, if we can put them on a trial that has a FLT3 inhibitor, we will, so that we can't do off-label prescribing in the UK on the National Health Service. You can do it privately, but not on the health service. So on the health service, they'll either get single agent gilteritinib, or on a trial, they will get venasa gilteritinib, or they will get intensive chemotherapy and gilteritinib in relapse. And or FLT3 inhibitor, I should say. And if it's monotherapy, we absolutely do wait. If they don't achieve complete CR, we wait till at least 6 cycles. If they show response after the first 2 cycles in terms of blast reduction, you'll nearly always see blast reduction after the first cycle. And then you'll see CRI, CRH, and then it hopefully will progress to CR. In terms of MRD, they're often still MRD positive at that point. It is more likely to be negative if you're NPM1 FLT3 as opposed to FLT3 alone. Okay. And then if you're FLT3 positive going into transplant, please use gilteritinib post-transplant.
Okay, all right. Dr. Kishore, this patient has been already exposed to midostaurin. So basically, we had a recent patient. So I was very much apprehensive to start single agent gilteritinib. So I started azacitidine plus gilteritinib. What is your experience on single agent FLT3, especially when they are exposed to another FLT3, and whether you should use it single agent as per this Admiral data, or whether you can use in combination? Dr. Kishore.
I think after listening to Professor Vyas, I think single agent can be given a try. And anyway, 2 works better than 1. There's no doubt about it. And what are we trying to achieve next? Like, are we going in for a transplant?
No, 36-year-old, we are going for a transplant. So yes.
Actually, then yeah, I don't find it so wrong out of the clinical trial to, just as Professor was saying, to use a combination, get a decent remission, and then to do on a transplant, and then put on gilteritinib maintenance post-transplant if the patient is FLT3 positive.
Dr. Sushil, I would like to get the opinion from you also. In this scenario, single agent, combination, what will be your opinion for this patient?
No, yeah, I think actually I would go even with the triplet if the patient is tolerating.
Aza-Ven plus gilteritinib.
Yep. That's based on MD Anderson's experience recently.
Yeah.
We were talking to Dr. Naval Davar, but again, Dr. Mark Levis is not so much in favor for it. But I think in the RRAML setting, he's a bit more open to using the triplet. I mean, MD Anderson is pushing the triplet in the upfront setting itself. So
There has been a phase 3 trial called the LAZE-WIN trial, where
yeah.
Aza plus gilteritinib was compared with azacitidine, and it showed almost doubling the PFS. But it was not with gilteritinib; it was compared with azacitidine.
Yeah. I'm talking about the phase 2 trial.
MD Anderson. But the problem with MD Anderson results are not being able to be. In the other part of the world, you can't show the same results. You don't have any toxicity, so that's why I was a little skeptical.
And if you are not able to use gilteritinib, what are you going to use now? Just I'm asking you, say
Aza-Ven.
Yeah, just do that. And then add on. So we can't be sure, because with our setting, relapse, a lot of multiple confounders. I think this all needs to be, we can't be very stringent on the doses also sometimes. So as I was saying, aim is to get on to a decent remission. So I think Sir has got
Professor Vyas,
can I ask Dr. Vyas?
Go ahead, Dr. Sushil. Yes.
No, I just, Dr. Vyas, your comment on the maintenance, there's been pushback, at least at our center, on after the Morpho trials results on AML maintenance with whether you go with sorafenib versus gilteritinib. What can you just give me your opinion? I mean, how would you respond to those criticisms after Morpho?
Sure, it's a great question. So the Morpho trial clearly shows an advantage for those patients who are MRD positive but not MRD negative post-transplant. And if you're MRD negative, do you give something post-transplant? My own view, and this is if you look at the patient in front of you, I would give a FLT3 inhibitor. I find gilteritinib is easier to give than sorafenib. Clearly, the two have not been compared head to head. So it's difficult to say if one will work better than the other for any individual patient. I do go with the MRD. And so if the MRD is persistently negative, I do it for a year. Some of my colleagues do it 6 months. But the relapse with FLT3 can be explosive. And so I'm just worried. I know what the Morpho data say, but it's a person's life in front of you. And no trial is perfect, right? I mean, even in those MRD negative patients, there were patients in both arms who were relapsing, right? So it's a belt and braces approach. But I do give something. The other thing I would say, just to ask the question, would you give monotherapy or would you give a doublet, or what would you give? Because that was the conversation before.
Yeah.
So, Aza-Ven gilteritinib is very myelosuppressive. You really have to be careful of dosage. And so you really can't give more than, in our experience, 7 days of Ven. If you're going to use the triplet, the Aza dose, I usually limit it to 5 days, 75 milligrams, and the gilteritinib 80 if you're lucky. And you may only give 21 days of gilt in a cycle. Another way of doing it is to give Aza-Ven for 1, maybe 2 cycles, and then do gilt monotherapy. That's another way of doing it. Another way of doing it is to give Aza-Ven and start gilt on day 14 and give gilt from 14 to 28 as monotherapy. There are different ways of doing it, and there is no known, unequivocal right answer. But am with Dr. Kishore. I suspect 2 or more drugs are better than monotherapy. And, it's unlikely that the FLT3 mutation is on its own, right? Very unlikely. So I would give combination therapy, and typically what we've done is put them on trials, but if somebody's not on a trial, and particularly if they have insurance, we tend to give 7 days of ven, 5 days of AZA, and the guilt, depending on how cytopenic they are, we'll either give them on day 14 or we'll start on day 1 to day 21. And there's slight variations.
Okay. All right. Thank you, sir. With available therapy, Dr. Sushil, in your experience in our Indian population, how many patients do respond to this treatment? You give this.
Which treatment?
In a relapsed refractory FLT3 positive, if you give gilteritinib single agent, or you give azaven, what is the response rate you have seen?
No, so we've not given it for that many, less than 5. So, but excellent response is what we've seen, and the rest is sort of secondhand data that we have. So, yeah, we hope to build up more experience with the drug.
So approximately 50%.
No, way more than that. I mean, I think even I think it was 4 out of 5. But if anyone hasn't responded, then it's probably someone who didn't make it till the response assessment. So
all these
I can't
patients have
remember
undergone
exactly.
transplant.
Yeah. So three have undergone. 1 was transplant ineligible. So yeah. That post-transplant guilt is not something that we are doing as a department yet. So I mean, it's good to hear Dr. Vyas's opinion on that. But yeah, so because after Morpho there was a significant pushback on that. But I think because we have not yet started FLT3 MRD testing. Once that comes in, I think then we would be able to select out that population for sure that would benefit from it. But yes, I especially I think the main thing is the way that they go into remission, and we are able to take them up for transplant, or because it's just so well tolerated. All the 5 patients, excellent tolerance, and one was actually a 78-year-old post-transplant relapse with the newly diagnosed FLT3 mutation breakthrough. And 1 year post-transplant was transplanted outside and came to us actually from Germany. And so they actually imported the gilteritinib from Germany, and we started it here. And even at 78 years old, she tolerated it. So,
all right.
Yeah.
So I think so. This was a group of
68 years old, sorry.
Who didn't do well before. So after gilteritinib, it's definitely a ray of hope for them. That many of the people
for sure.
for transplant. Definitely, that's a good news. So we should use it more often. I think so. There is solid data after midostaurin or sorafenib to give gilteritinib. You have Chrysalis and Admiral group of patients, even those who has undergone transplant, and after that, when they relapse, single agent gilteritinib has done better than salvage chemotherapy. So we should not worry on starting gilteritinib. Now, regarding transplant acute, we are almost on time. That means we are going to finish our allotted time. So fast, any determining criteria for eligibility for transplant, any concerns you have before giving gilteritinib during transplant or anything like that, Dr. Kishore?
I mean, looking at the acceptance, the trials and off the trials of the personal experience, I think this is wonderful. Like the main problem with the early AML things was the say FLAG-IDA, the toxicity even before getting onto transplant itself would have stopped many patients going through that. So anything that is tolerable, anything that can give a decent control, that is what we are looking into. That is also was missing in AML for a long time. I think gilteritinib is doing a great job. I mean, it's a combo too at the end of the day, like when and everything as a combination has made, especially when Sushil was talking about the 68-year-old, we would have never imagined 10 years back doing anything except say palliation. So I think wonderful. So
Professor Vyas, that means the recommendation tell to stop the gilteritinib 7 days before transplant. Any of the higher risk VODs or something with Trioflu or something when we give gilteritinib, any of the concerns you have to keep in mind?
Yeah, we stop gilt 7 days before transplant for a washout. Absolutely. And we do not resume gilteritinib until full count recovery or at least platelets greater than 50 and neutrophils greater than 0.5.
Okay, all right. So in this study also, where they have taken for transplant, compared to a salvage chemo, the rates were more, those who have undergone transplant. But still there is a lot of work to be done there, because if you see how many people are alive for more than 2 years, the numbers are very few. So I think so even gilteritinib is not filling the gap, but it is better than many of the standards which we had. That is the thing which you have to take home.
Yeah. So just remember, this is a population, most of this population will not have seen prior TKI. So going into, if you were to do this study again today, it would be slightly different.
Yeah.
And the second thing I would say is that very few of these patients had any kind of azaven salvage or azaven gilteritinib salvage or anything like that, right? So I think you can, to Dr. Kishore's point, you really need to tailor your salvage treatment not to make the patient ineligible for transplant.
Yeah.
Use treatment that doesn't beat up your patient.
Yeah.
That
Make them
treats,
more sick. Yeah.
that is tolerable, and they go into transplant in the best possible performance status.
Yes. Dr. Sushil, go ahead. You want to add something?
Actually, I just wanted to know, Dr. Vyas, Dr. Mark Lewis once mentioned to us that gilteritinib puts patients into a sort of, I mean, they could still have blasts, but it's sort of an AML, which is not an AML. He said that, it just goes on for many years with, a few, like a sort of a benign kind of disease status. And so you really don't need to sometimes target the MRD negativity too hard. Especially in that, I mean, he was talking about a transplant ineligible group.
Bacteriostatic than bactericidal.
Yeah, something like that. So, one sort of slow burning kind of disease state. Is that something you see? I'm just curious what your opinion.
I think in younger patients, that's not the case.
Mm.
I think in some older patients where they have other mutations that are much more like MDS mutations, there are all these secondary AML mutations, splicing factor mutations, all this kind of stuff. If he's talking about those patients, maybe, but in practice that I've seen, ITD is not a trivial mutation. Most patients have proliferative disease. Now, if he's saying that you have MRD positivity on gilteritinib, you continue gilteritinib and it suppresses the clone, and so you can live with the disease, that may be true. He has more experience than I do. And that may be true particularly for older patients. But in general, if the patient is eligible for transplant and it's in first relapse and you've salvaged successfully, take to transplant.
All right. About the duration post-maintenance, post-transplant, I think the Professor Vyas has told that he looks at the MRD and he still believes in some fixed duration. And that is more good for our population, I feel, even though we don't have that.
I think, look, do it for 6 months minimum.
Yeah.
If the patient can afford it, or if the MRD is positive, do it for 12. Typically by 12, most of them are MRD negative.
Okay. But there is a definite post-transplant analysis from this trials has shown that if you continue gilteritinib, that means if you don't start gilteritinib, the survival is inferior. So I think so MRD is going to be the key.
Yeah, it is.
Documented. Yeah, right. Yeah. I think so we'll stop here. Prajakta, we have overshoot time, I think so. Anything more Professor Vyas can add?
No, just a real pleasure to participate, and I've really, really enjoyed this.
It was a good insight for us, sir. We are new with SOSPATA. We are still working with us. That's why it was good. It was our privilege and pleasure to have you.
You're excellent clinician, always. I go to India maybe once a year to Ahmedabad because my mum lives there. So I hope I can meet you at some point.
The next time our meeting will be planned according to that date.
Sir has been quite practical. So that's the NHS
way. The thing with UK is they are more practical.
Yeah.
The other things are just, they tell the guideline which is not possible in our country. So that is why.
Thank you, Prof.
Thank you very much.
Thank you,
Thank
Professor. Thank you.
Have a good
Thank you.
evening.
Thank you very much, Dr. Prashant, Dr. Vyas, Dr. Kishore, as well as Dr. Sushil. It was a huge pleasure for us to listen to you all today. We had immense learning from these discussions, and we would definitely like to continue with such smaller events. Thank you, Dr. Vyas, for being here and also for adjusting your schedule as per the timings. And
you.
thank you to everyone else. Sir, we have a few questions for you, but probably I can send it to you personally and we can discuss it in the next session, if that's fine.
Yeah, that's fine. Thank you. Have a good evening.
Thank you.
Thank
Thank
you.
you. Thank you.